Today, the modern anesthesiologist is really the expert in perioperative pain management. I think that we work in concert with our surgical colleagues as well as other consultants in emergency medicine, internal medicine, even palliative care, to make sure that patients who are admitted to the hospital, or have outpatient procedures have the best possible pain relief. I think that as anesthesiologists, we really have a natural leadership role in this area. And I can speak, at least on behalf of our American colleagues through the American Society of Anesthesiologists, that anesthesiologists have taken the lead in trying to coordinate better pain management for all surgical patients by partnering with societies outside of our traditional anesthesiology and pain medicine societies. I think that we as anesthesiologists are really the physicians, who have the expertise, to manage pain, as well as assess the quality of pain management, for patients who undergo surgery as well as other invasive procedures. And these principles really help guide us in terms of using the best available evidence to provide great quality care for our patients. The opioid epidemic that has primarily affected North America in recent years has really brought a great amount of attention on the paucity of evidence in addressing pain around the time of injury and around the time of surgery. And I think for many years, up until the attention and rightful attention given to the opioid epidemic, I think that surgical pain management was really dominated by a sole class of analgesics, opioids. And although have been some benefits, because this is an important class and very potent class of analgesics, we have definitely moved away in terms of our evidence to support sole opioid use for pain management. The idea that every single patient who has surgery should have an intravenous opioid patient-controlled analgesic pump, or be prescribed dozens and dozens of pills that are highly potent and can fall into the wrong hands after even minor surgery, I think has passed. There have been a number of different positive opportunities that have come from the opioid epidemic. I think that we've made some really great strides in anesthesiology and perioperative pain management to try to decrease our over-reliance on opioids. We've increased the use of multimodal analgesia. We've started to stress the importance of non-opioid analgesics, like the use of regional anesthesia. But also, I think what's been even more important has been the partnership between anesthesiologists and surgeons. I think that surgeons have recognized the expertise of anesthesiologists during this opioid crisis in order to leverage some of our partnership and collaboration to help patients. It's not to say that opioids have lost their purpose, because they have not. And they're still very important medications, but they're not the only medications that we can use for pain. And so I do think that it's, even though our over-prescribing problem in the United States has gotten better, I do think that there's still great opportunity to even do more. And that really leads us to this concept of surveillance and management of patients post-discharge. So one of the big problems that we have in the United States has been trying to get better evidence-based prescribing practices in terms of opioids. I do think that there is a role for anesthesiologists and transitional pain services in trying to address the problem of continuing prescription of opioids or overprescription of opioids, as well as long-term opioid use. But it's a very different model of care than what we normally consider the traditional anesthesiology practice. Transitional pain services really entail care that extends beyond the hospital walls. It goes beyond hospital discharge. It really allows proper surveillance for patients to make sure that they are on the normal recovery trajectory in terms of pain management, in terms of pain resolution, in terms of quality of recovery of care after normal surgical procedures, as well as the normal tapering and cessation of opioid use. Now, I think that persistent surgical and post-surgical pain and longer-term opioid use oftentimes are conflated, and we use them interchangeably at times. But that's simply not the case. And I think that our attention to persistent post-surgical pain has been much longer than our focused attention on opioid overprescribing. I think we've recognized as anesthesiologists that surgery itself represents a major trauma, and that major trauma can lead to chronic pain. And certain surgeries have definitely had much more attention. And so when we think about prevention, prevention has multiple different layers, and clearly primary prevention is not possible. Primary prevention would only occur if you avoided the insult entirely. So if we avoided surgery, you would never get persistent post-surgical pain. But that's not what we're talking about. What we're really talking about is secondary prevention. And secondary prevention really entails good surveillance. It means constant reassessment. It means better follow-up of patients. I think that early detection, as I mentioned, as part of secondary prevention, allows us to intervene. When we know that a patient is not following the normal recovery trajectory, then as a specialty, transitional pain or an extension of acute pain, which I think is properly lives within anesthesiology, can take care of these patients to make sure that they're on the right balance of multimodal analgesia, perhaps to offer interventions. And we do now have interventions that represent a larger family of regional analgesic techniques that can last longer than our short-term local anesthetic blocks or local anesthetic infusions. I do think that untreated persistent pain, untreated greater than expected acute pain, does have a tendency to be associated with long-term opioid use. And this is the way that I think we as anesthesiologists can combat long-term opioid use is by being more involved in patient care after surgery. This is an area of medical care that I'll tell you, surgeons are not fighting us over. They already have enough to follow in terms of their postoperative care. And they're not specialists in acute pain and the transition to chronic pain like anesthesiologists are. So to me, I think this is really a great opportunity. We as anesthesiologists have always been innovators. And I think that this concept of filling a gap, of finding problems that need to be solved, this is what we do best as anesthesiology. And I think that transitional pain services represent an important innovation in the field of anesthesiology and pain medicine.